Good morning. So I'm honored to invite the next session, which will be the last half of the scientific session 1. And I'm glad to introduce this. And so the first speaker, I'd like to invite Arturo Bonometti from Italy to be speaking about about more than just LCH, the diagnosis and clinical significance of the mixed histiocytosis.
Okay. So it will be a hard job for me to continue after the previous speaker. Anyway, my name is Arturo Bonometti. I'm a pathologist and research fellow at Humanities Research Hospital in Rozzano, which is close to Milan. And I will thank the organizer to have invited me to discuss a little bit about the issue of mixed histiocytosis. Okay. I have nothing to disclose. Well, first of all, the definition of mixed histiocytosis. I believe that the best definition for this condition would be the synchronous or metachronous occurrence of lesion with LCH and NLCH histopathology, meaning with histopathology a combination of morphology, of course, histopathology, immunophenotype, but also the aggression of tissue, which is typical of Langerhans cell histiocytosis and is not found in non-Langerhans cell histiocytosis. Mixed histiocytosis were first described in this article in 1984 by Nancy Brower. Look at the title because we will discuss a little bit later. And were named after an article published in 1991 by Vital and colleague. But probably you, all of us basically, we have learned about mixed histiocytosis very much after this article by the French group in which, considering a cohort of patients diagnosed with Erdem-Chester disease, they also highlight the presence of a sub-cohort of patients that also have Langerhans cell histiocytosis lesion, and they were characterized by having a very large number of cases with BRAF mutation comparing to the general ECD population. Because of this article, mixed Langerhans cell histiocytosis and Erdem-Chester disease was also included in the revised classification of histiocytic disorders. However, mixed histiocytosis, according to the definition I gave you before, is not limited to LCH-ECD overlap. And indeed, if you look at the literature, you will also find other possible clinical pathological scenarios that I will show you very briefly with 3 patients that we followed in Italy. The first one is an adult male with a diagnosis of multisystem risk organ negative LCH. He was treated, achieved complete remission, but later, 2 years later, he developed a nose nodule with this histopathological feature. He was diagnosed with having a residual organ disease of the skin, and with long bone lesion that were identifiable as Erdem-Chester disease. He was treated again he achieved complete remission, but after 2 years, in 2017, he presented at emergency department with pancytopenia and peripheral blastosis, and that's the bone marrow biopsy. Half was replaced by a population of CD34 positive blast, so it's acute myeloid leukemia, and the other half was Erdem-Chester disease. I consider this to be a first type of mixed histiocytosis, which is the most common, but another possibility is this one, which is also subject of a poster from the Cincinnati colleagues, and is the case of a young child with multisystem risk organ negative LCH that is treated and 2 years later develop cutaneous juvenile xanthogranulomas that remain stable even after a topical steroid. A third possibility, which is especially interested for histopathologists, is the case in which you have 1 biopsy and 2 flavors. So a single nodular lesion on the back of an 8-year-old child, in which on the top you have epidermotropic infiltrate of Langerhans cell histiocytosis, and in the dermal and mid-dermal infiltrate akin, once again, residual organ disease. Considering these 3 patients that we saw in Milan, I tried to understand better this condition studying the literature, so I tried to perform a systematic review of the literature. Considering, according to PRASMA guidelines, only those patients, so those cases, most of were case reports, that were histologically confirmed, so with a histologically defined mixed histiocytosis. And I could find 105 patients that I try also to subdivide it according to the clinical pathological scenario I just showed you. A first type, which is also the more frequent type of mixed histiocytosis, was represented by therapy-naive patients with mostly multisystem histiocytosis. The mean age of diagnosis was 34 years. The vast majority present with LCH lesion, and after a median of 0 months, they also have a diagnosis of a non-Langerhans cell histiocytosis, most frequently of ECD. A half of patients also present with central nervous system involvement and or diabetes insipidus, and 17% were risk organ positive. Interestingly, these patients were not just histologically mixed, but also on a radiographical point of view, 40% of cases showed osteolytic and osteosclerotic lesion. As highlighted by the article by Hervier and colleagues, 90% of tested cases resulted to be BRAF V600 mutated. And trying also to perform survival analysis on literature data, I could demonstrate that actually this type of mixed histiocytosis compared to the other two that I will show you in a second have a 10-year disease-specific survival that is a little bit less positive, so 80% survival at 10 years. A second possibility is described in the literature is that of LCH patient that develop non-Langerhans cell histiocytosis lesion after receiving systemic chemotherapy. So these are more frequently children with a median time to second diagnosis from LCH to NSH of 2.5 years. Most frequently, these were once again multi-system patients, especially with bone lesion. And the second diagnosis was most frequently of juvenile xanthogranuloma or adult xanthogranuloma according to age. Once again, BRAF V600E mutation was found in a very high percentage of patients, 80%. Of course, these patients have the longest follow-up, but is just about 42 months. A third group is the case of single system patient that present in the same lesion, so they are histologically mixed, with a Langerhans cell histiocytosis infiltrate and a non-Langerhans cell histiocytosis infiltrate. Once again, also these were more frequently children, and the second diagnosis was very frequently of Rosai-Dorfman disease, especially cutaneous lesion with both LCH and RDD. Of course, these were very frequently skin lesions, so unifocal skin lesion, and of course, a very high percentage of these patients could achieve a complete remission after surgical excision of the single lesion. Another topic of interest could be the association of mixed histiocytosis with hematological malignancy. This is basically the same of LCH and ECD. Around 10% of mixed histiocytosis patient associates with hematological malignancy, more frequently with myeloid lineage malignancy. Shared clonality is only described in 2 cases, and according to the survival analysis that I performed, this association did not impact with patient survival, but probably this is just because of lack of data, because otherwise in LCH and ECD, this association impact a lot with patient survival. After the clinical pathological feature that I could get from the literature, I also try to understand, or anyway, I asked myself, what could mixed histiocytosis tell us regarding the relationship between LCH and ECD? This because, of course, we know that much of the molecular landscape of these two conditions is shared, but also something else that is very well described for LCH and less well described for ECD, that is the oncogene-induced senescence. Both these are histiocytic disorder with the same or almost the same mutation. They have very low proliferative index, and also they have systemic inflammatory picture. But this issue, this concept, probably is the other side of the coin of something that, on a histopathological point of view, was described in 1944, and that also histopathology basically have forgotten, that is the histological maturation of LCH. Indeed, LCH present to the histopathologist both if you leave the lesion untreated and if you treat the lesion with this spectrum of maturation that goes from the classical eosinophilic granuloma, which is full of LCH cells, eosinophils and lymphocytes, to some lesions that are first granulomatous, then xanthomatous, and with a substantial decrease of LCH cells. And the end stage of a LCH lesion is that of a fibrotic lesion that was described in this article by Jennifer Pikarsik and Ronald Jaffe as a fibroxanthomatous, basically regression. you will find this maturation in every tissue involved by LCH, including, is very well demonstrated in the bone, but for example, in the liver. Pathology do know that sometimes you cannot distinguish an LCH involvement of the liver to a primary sclerosing cholangitis. It's impossible because you have no cells, Langerhans cell, histiocytosis cell there. But therefore, there is also something else. With a fibrotic lesion, a fibroxanthomatous lesion, we cannot distinguish on a histopathological point of view LCH from ECD, which has the same lesion, fibroxanthomatous. And therefore, epidemiology, clinical findings will help to perform a correct clinical pathological diagnosis. But this concept needs also to recall something that is basically the very first description of both LCH and ECD. That's this. LCH was not firstly described in children, but was actually first described in adulthood with the so-called Handschuler-Christian disease, that now we will call Langerhans cell histiocytosis multisystem risk organ negative. But actually, also in that it was considered the first description of ECD. Chester described the same thing, so Handsche-Krankheit, which is Langerhans cell histiocytosis. So Chester saw two cases in 1930 that he believes to be Handschuler-Christian disease, so Langerhans cell histiocytosis. And only in 1972, Henry Louis Jaffe, in his book, considered these two patients by Chester and a third patient that he sees as a different kind of disease that he thought to be a storing condition of cholesterol. And coming back to mixed histiocytosis, actually is mixed histiocytosis what lead to the physician to consider the Erdem-Chester disease actually a histiocytosis and not a lipidosis, because N.C. Brouwer collected all the cases described of Erdem-Chester disease since 1984 and show that many of these patients, that were around 10 patients, shows both feature of LCH and ECD. So I will end my presentation with a sort of provocation, but could it be that actually LCH and ECD are just two spectrums of a clinical pathological continuum, and therefore mixed histiocytosis is just everything in between these two ends? So I will just thank you for your attention, and thank you, well, my few colleagues from Milan. We follow adult histiocytosis patients, and especially thank you the Associazione Italiana Ricerca Histiocytosi Onlus, which is the association of patients that allow us to do research on histiocytosis in Italy. Thank you very much.
Okay, I'd like to open the floor for questions. I'm going to take the first questions. We have a couple, enough time for about 2 questions. So, okay, Astrid has one question here. So.
Well, thank you very much for this intriguing overview, a little bit of the past and a little bit from now. I just have maybe more of a philosophical question. Do you really think that ECD and LCH are separate disease identity if you look under the microscope? I'm not talking about clinical presentation, but just when you look at the microscope as a pathologist. Well, I just want your view on this, because I think that it's all the same. It's just a matter of plasticity within the myeloid system. Mm-hmm. It adapts according to where the cells go, land, and do their job.
How they moderate and how they perform. Well, I really believe that at least for Handschuler-Christian disease, at least if we consider young adults with multisystem risk organ negative histiocytosis, probably they are actually the same disorder. But probably they are not the same, for example, of what we used to call Hashimoto-Pritzker disease or Ablet-Receiver disease, so the risk organ clinical picture with a very acute onset. That may be a different thing. Also because those cases, the acute risk organ positive cases, on a histopathological point of view, may be also a little bit more blastic, like a sort of a solid leukemia. Otherwise, these patients, multisystem risk organ negative, very frequently show, on my point of view, a degree of maturation, more or less.
Any other questions from the floor? Okay.
Thank you for your presentation. I have a very simple question. From our experience in French registry, these mixed cases are much more frequent in adult and more with aging. What is the trick between mixed mixing and aging?
Well, I really don't believe there is a problem of aging in a broad sense, but probably just something that has to do with the maturation, the age of the lesion. Because I believe that in some patient with LCH in the adulthood, well, we know that basically both LCH and ECD in the adulthood may be misdiagnosed for 10 years, 3 years, 10 years, or a very long time. At least if you don't know very well the disease, and in many countries, some patient pass from a center to another for years before to get actually a diagnosis of histiocytosis, or anyway, it is like this in Italy for adults. But I believe that probably in adults you have the time span to lead to the lesion to maturate. That's the reason, probably, for which we see mixed histiocytosis more frequently in adulthood, I believe.
So that was a great overview, and I just have a question for you, and maybe Jen can chime in on this. Is like, I think that you only find mixed histiocytosis if you look for it, right? I mean, the ones that are histologically clearly different jump out at you, but I mean, it's not typical, as far as I understand, to use CD163, factor 13, FASN, et cetera, on every single sample. And as we've started to kind of do that in Texas, we see like basically every lesion has some degree of kind of a mixed phenotype. And so like how are our expert histologists dealing with this from a classification perspective?
Well, I totally agree. I believe that at least for type 1 and type 2 mixed histiocytosis, we are just dealing with LCH that is maturate. Otherwise, probably type 3, I just describe it because I find it in the literature and was corresponding to the definition I give of mixed histiocytosis, but probably that's just about having a LCH with a huge inflammatory component aside to the LCH infiltrate, probably.
Just a small comment. Oh, sorry. No.
Okay.
Just a small comment. Thank you for this excellent presentation. Concerning the age and concerning the testosterone, maybe, just to make the link. Well, the cases of mixed ECD with Rosai-Dorfman disease are almost exclusively adult male patients. So probably the age and the testosterone may influence the differentiation. And well, this is...
And different morphology also. Thank you.
Okay, thank you.
Thank you very much.
So now we need to move on. So I'd like to invite Egle Kvedaraite from Karolinska Institute here to talk about Notch dependent crosstalk between dendritic cell type 2 and dendritic cell type 3 monocyte lineage promotion from its the pathognomonic LCH program. So, Egle.
Okay. Okay, so yes, so hello everyone, and thank you very much for the opportunity to present our research and my favorite project. And I thought I would start by just summarizing what we found. So we could see that LCH cell pool has contributions from both monocyte DC3 lineage and DC2 lineage, and that those two lineages crosstalk in gaining the LCH phenotype, and this is happening through Notch. So, and I will show you some data, hopefully convincing, of those two messages. But first, some background. So, what do we know about human dendritic cells? Recent findings in the field of human dendritic cells have opened up new avenues to study those cells and to learn more about them in different diseases. So here we have, progenitors, different types of those, and these are, antigen-presenting cells with specialized functions. And here I would like to draw your attention to a newly described dendritic cell type 3, so DC3 over here. So it is a completely different lineage of cells, so they do not belong to DC2 lineage, and they are not monocytes either. And as you can see, they share some markers with the DC2s, but they also are positive for the markers that we typically associate with monocytes or macrophages, CD14, CD163, and CD206. So this is on DCs. And then when we it comes to the LCH background, well, we all know that BRAF V600E is found in approximately half of the lesions, and this had opened up new avenues, treatment avenues. And yeah, mutants can be found in circulation, and it has been even proposed that maybe yolk sac-derived macrophages can be involved in, LCH pool formation. But now we all mostly would agree that LCH has its origins in a hematopoietic system and coming, from bone marrow. And the debate has been for a long time, whether the cells that we are seeing are mostly similar to DCs or if they are more monocyte-like cells. So to answer that, we had a following. Oh yes, and also from therapeutics point of view, also mentioned this today previously. Like we know that BRAF inhibition, saves lives, but as soon as we wean off the patient from the treatment or stop the treatment, the disease most typically will come back. So this means basically that we still need to understand more about LCH cells to, their biology, to be able to effectively eliminate the pool, preferably upfront. So we need, to find new targets and to understand the heterogeneity and their ontogeny at the lesional site. And this was our study design. So we had children with LCH, and then we did index sort, high-dimensional microscopy, and co-culture to validate our findings using HLA-A2-based lineage tracing. And I will spend a little bit of time just explaining this little part with index sort. So it means that we took each single cell from the lesion, put it in a well, and got both protein flow cytometry definition of a cell, as well as RNA definition of the cell, meaning transcriptomics. And like that, we could define our cells not based on the cluster that they belong to, but really on each individual single cell level. And this is a little bit important if you think that later on, in the next step, you would look at the heterogeneity. So it's very, very important at the very beginning to be able to proficiently separate LCH cells from the rest of the mononuclear phagocytes also present at the site. Okay, so this is analytic pipeline. So we could, single cell index data with RNA-seq data, and then we could define each of the cells and LCH cells and different programs, look at the core genes, heterogeneity, and we validated this using, protein analysis, but also looking at the spatial data and as well as this culture system. Yes, so the first step, which was, as I said, a little bit important, we could delineate LCH cells both on protein and RNA level. This is illustrated here. So this is protein, and this is RNA. And you can see that LCH cells, represented here in pink, separate very nicely from the rest of the mononuclear phagocytes. And importantly also, it corresponds, the identities found on protein level correspond to the clusters defined by RNA-seq. And apart from LCH cells, we also looked at, DC1s, DC2s, DC3s, pre-DCs, monocytes, PDCs, and reg-DCs. Yes, and then when we did that, so separating, LCH cells from the rest of the mononuclear phagocytes, we could look at the heterogeneity, where we found two major clusters, here named cluster 0 and 1. So blue is 1 and 0 is red. And then we took those cells and subjected them to an analysis called CMAP, so what is happening in this analysis is that we take all the cells in the middle, and then we ask them to polarize either towards mono DC3 signature or towards DC2 signature. And this is actually DC3 signature, but since those signatures on transcriptomic level compared to DC2s are very similar, we call them DC3/mono signature. And then you can see that the cells from cluster 1 mainly corresponds to this part. So there is this dual separation between mono DC3 and these cells over there that end up in this cluster 0. And this was, of course, important to validate in more data. And for this, we used the following setup, where we used a fantastic data set from Dr. Hutter, where we integrated our data with this data, and then we could show, well, this is just the same exercise, doing CMAP on the 10x data, where you can see this, again, dual separation, that kind of come into the middle of DC2s and mono DC3s. But then we had this question, are both of these populations neoplastic? And to be completely honest with you, we thought they were not. So in the beginning, the idea was that, maybe these DC3/monocyte-like cells are just macrophages coming into the site, and they are not really LCH cells. So for that, we did this experiment where we sorted lesional cells into, singlets, live, 45 positive, DR positive, LCH cells, and the rest, and then these gates over here. And you can see that mono DC3-like cells, so these cells, they are just as equally positive for the mutant as the other two populations, or like the DC2-like cells, whereas non-LCH cells had very, very low levels of this mutation. So all of them are neoplastic, and for next was important to validate those the presence of those cells in the tissue context. So for that we had the following experiments. So we took bone, skin, lymph node, and analyzed the cells within CD207 positive area and outside of it. And for that we used high-dimensional imaging platform Maxima, where you can stain a lot of antibodies subsequently on the same slide. And then we looked at localization of different subsets, as well as measured CD147, which is a little bit interesting because it's a metalloprotease inducer, and you know that LCH lesions are very lytic lesions sometimes, so this could be interesting from that perspective. But also it has been demonstrated that CD147 is a notch regulator, and it will be a little bit important later on when I tell you about the program, or how the LCH program is obtained on those different lineages. Okay, so what did we find? So we looked at the skin. So this is a skin sample where we found those two subsets, and we did the same in the bone samples and lymph node samples, where like this dual separation seemed to be apparent. And then afterwards, we went to measure the levels of this molecule within the two subsets. So basically what you're seeing here is the segmented CD207-based segmentation, and then measuring different things of the list of 30 antibodies that we measured on the axis. And so yes, when we looked at this marker over there, we could see that the levels of CD147 were higher in mono DC3-like subset compared to DC2s, and that's how it looked in the tissue. All right, so then this question that I just mentioned, how do these cells gain their phenotype? And I mean, we didn't start from zero. Of course, there's a lot of data already out there that has been studied. So what we did here was that we, again, did this experiment where you culture monocytes, DC2s, and actually we also included DC3s, because we know already that for DC2s, to acquire the CD207, CD1 high phenotype, you don't really need notch ligation, which is necessary for monocytes. But what is new here is that we also included DC3s, and apparently they also need it. So DC3s also need this notch ligation just as monocytes do in order to gain CD207, CD1A high phenotype. And a little bit of an interesting fact is that when we took the transcriptome of these and those cells, so either monocyte or DC3 culture, and then we subjected the same cells, like from this cluster that is mono DC3 cluster, to the signatures of the respective culture, the majority of the cells ended up with DC3s. Of course, this is not an evidence, but it's like definite evidence, but I think it will be interesting for the future. Okay, and then another piece of evidence going to notch was that in the lesion, when we looked at the cells, the communication between the cells, so basically we looked at the receptor-ligand interactions between the different subsets and all the other lesional cells that we found in mononuclear phagocytes, we could see, interestingly, that there were these predominant notch interactions, and they were present, and as you can see, between the LCH subsets. So this was interesting, and this was another piece of evidence that led us to the next hypothesis, which was that, well, here. So we know that LCH state of program is notch dependent in monocytes, and also now we know in DC3s. But could it be then so that DC2 lineage is able to provide this notch ligation to the monocyte DC3 lineage, giving the Notch receptor interactions that we saw ex vivo, and also the fact that they are so closely related into the, like in the lesional environment that as we saw from the microscopy. So for this, we designed this experiment where we have HLA-A2-based lineage tracing, and we culture DC2s together with either monocytes or DC3s using these culture conditions, and we also blocked Notch signaling by using gamma secretase inhibitor. And then the readout was this high subset of CD27 CD1A high cells. So what did we find? Actually, DC2s can induce this phenotype alone with no other Notch ligation in the present. So if you can see the culture DC2 monocyte, DC2, DC3, you have appearance of those high cells on monocytes as well as on DC3s, and this is just quantification. So both are go up, and this is with the help of DC2s. And then interestingly also the ligand DLL1, this is a Notch ligand for Notch1 for example, it also goes up as you get these, the expression of CD27, meaning that the LCH pool itself is able to perpetuate this program most probably. And we could nicely confirm this in the lesions as well, where we saw that Notch1 and DLL1 were differentially expressed specifically on LCH cell compared to the rest of the mononuclear phagocytes, where CD14 positive cells correspond to the larger part of it. Okay, and so, well, the last puzzle piece was, of course, to block it and show that, in fact, this can be blocked by Notch inhibitor, both in mono or in especially DC3 culture. So to sum up, we can see, I hope I convinced you a little bit at least, that LCH cells derive both from DC2 and monocyte DC3 lineages, and that Notch-dependent crosstalk between those two lineages promote this LCH program that we, in the end, are seeing. So with that said, I'd like to thank everyone, all the patients and their families, for their generous participation, and of course, everyone who contributed to the work, especially in the labs of Florent, Jan-Inge, Jimiao, and Matthew. And I'd like to highlight also one more person that was very, very helpful with the culture, and it's Paul. And these two pictures are actually taken at exact the same time. One is at Karolinska, and another one is Newcastle, where we are doing revision experiments. So Paul is working on Notch, and I'm working on osteopontin validation. So with that said, I thank you for your attention, and I'll take questions.
So thank you, Egle, for the very interesting presentation. And I will now open the floor to questions. And also anyone online, please type your questions in the Q&A box, and I'll be monitoring this. We have enough time for maybe a couple of questions only. The first, the floor. Any questions from the floor? Oh, there's a question. Okay, I see.
Oh, hi, it's a great presentation. So what about the DC3 and IL-12 and TNF? I saw them producing that a lot. Does that change a lot with the Notch ligand from the DC2s? Thank you.
So I think I did not entirely understood the question. Maybe if you, so you are wondering about
like
how
in your co-cultures with DC2s, did you see more IL-12 being made by DC3? Mm-hmm. Like, does Notch affect that much, or you haven't measured it? Just
no, we did not measure it, but nevertheless, it's a very interesting question, because we know that both DC2s and DC3s are able to produce high levels of IL-12, as well as IL-23, for example. And it would be very interesting, of course, to find out how this interaction between the two lineages, both in LCH but also other contexts, whether that may affect their functional consequential behaviors, such as cytokine protection and IL-12 production. We didn't mention that, but I think this concept where two myeloid lineages communicate in order to gain a certain phenotype or go into a certain differentiation direction is very interesting, because, for example, recently it has been described that IDO1 positive DC1s, they are, through metabolic regulation, also influencing tolerogenic so perhaps like the opposite of wild, but like it's, tolerogenic behavior of DC2s. So that has been recently described, and I think this is just like and that was like through metabolism. And so here we describe a notch-dependent interaction between the two lineages, and I think I guess there are so very many different ways through which those cells can communicate. We're not just one example, but well, especially because Notch has also already previously has been implicated in LCH and gaining LCH program. But no, we did not go into the functionalities of those different lineages when they are together. Thanks.
Okay, any other questions from the floor before we close the session?
Just one.
Okay, thank you. We can now close the session and adjourn for lunch. I think there's